That's a very important point on which we can bring this symposium to a close. At the outset, when we were looking at the immense Garfield dataset as it currently sits, and of course we have many years of follow-up still to perform, one further cohort still to include in the coming 11 months, we were interested in trying to understand what longer-term outcomes in newly diagnosed and prospectively followed patients with atrial fibrillation are, and you've seen the data, interestingly, in this symposium, that demonstrates that death represents an important burden in this broad population, really unselected in terms of their ability to enter a registry with no requirement for treatment and no exclusion criteria apart from an inability to follow up patients, and that death burden is a persistent risk, of course with an important and ongoing risk for both stroke, systemic embolism and major bleeding in a cohort where 60% of patients initiate anticoagulant therapy at baseline. Ethnicity and gender appear to be important potential factors, and we've had a very interesting debate on how we should interpret those findings and understand how advice and guidelines on the degree intensity of anticoagulation be provided for populations outside the world, and particularly outside Caucasian populations. A very interesting discussion on the potential impact of comorbidities, and indeed whether features such as chronic kidney disease or indeed smoking need to be taken into consideration, whether there's enough by way of risk factors currently for us to focus purely on low-risk populations, or indeed because we still see important underuse of appropriate and effective anticoagulation in patients with known risk factors, that identifying other risk factors helps us both to improve the proportion of patients anticoagulated appropriately, but also to start focusing more on the appropriate and effective management of comorbidities to improve clinical outcomes. Because much of the burden in newly diagnosed atrial fibrillation over the first 2 years is potentially burden not modifiable only by anticoagulation, but the use of anticoagulants in integrated care pathways, also focusing on the appropriate management of comorbidities. And then, of course, I think we've seen striking, reassuring, and it shouldn't be surprising data that shows us that if you're going to anticoagulate, anticoagulating effectively, in the case of vitamin K antagonist with an appropriate target INR achieved consistently, has a profound impact on outcome, but a failure to achieve that actually does our patients a great disservice. And we heard from Professor Haas a plea for a look at what we should consider the standard of care to be, and whether agents associated with a fluctuation in anticoagulant control should remain an important part of the armamentarium or not. Now, I'd like to acknowledge, first and foremost, the participants in this large global registry, some 45,000 individuals who have agreed to participate, our steering committee, our national coordinators, the over 1,000 sites and site investigators and their staff involved, the staff at the Thrombosis Institute and Dr. Gloria Kayani, who run this program, Quintiles, who are our partner CRO, and of course Bayer Pharma for having provided this unrestricted grant over a number of years to allow us to continue this very, very important piece of work. We'll have more data to share with you during the Congress, and that's laid out in the Congress booklets. Those are data not presented in this symposium, and of course we'll be back at ESC next year, 2016, with a further update symposium. Thank you all very much indeed.